I guess that means that everybody knows me. So I'm going to talk about complexities overlooked. Things may not be what they seem. First of all, I have nothing to disclose. I'm going to present a couple aspects of what we presented in this paper. This is a very recently published paper by the Gang of Four. And just to make sure that we understand each other, this is FD, what comes through the common gas outlet, that's the concentration or the fraction. Fi is inspired, Fa, big A, is alveolar.
And the word D stands for delivered, is that correct?
Yes, delivered, yes. That's exactly right. You're a fast reader. First, the FA-FI curve and anesthetic uptake. When our textbook discuss anesthetic uptake, this is the graph that we are shown all the time. This is the classical FA-FI curve presented by Ted Eager. Everybody knows this. Everybody realizes when we talk about uptake, we talk about this. And we have to assume, however, and not everybody knows this, we have to assume that this experiment is done with high fresh gas flow with a constant Fi of 1, whereby we look at the rate of rise of the alveolar partial pressure of different agents. It has a significant advantage. It's simple. We all seem to intuitively understand this. But there are some disadvantages. First of all, the Fa is quite variable. We start off low and then we gradually get higher and higher. And it keeps getting higher and higher and higher until it approaches Fi. And that is not really what we do in real life. In real life, we aim towards a constant Fa, a certain depth of anesthesia. Because of the high fresh gas flow, this results in a lot of waste. Obviously, that is not how we practice today. Using a fresh gas flow higher than minute ventilation, 6-7 liters per minute, is just not acceptable anymore. And these graphs that you see here may be confused with uptake, because after all, where is uptake in that curve? We know what the effects are of cardiac output on these FA-FI curves. Increase in cardiac output will push the curve down, and that's more significant for higher soluble agents than less soluble agents. We know what the effect is of ventilation. If we increase minute ventilation, the curve is pushed up. And again, that's more significant for high soluble agents than for less soluble agents. And we know what the effect is of solubility on the position of the curve on this graph. We know that the higher the graph is, the less soluble the agent. Therefore, the faster the Fa approaches Fi. But the question is, where is uptake in all this? It's just not there. Actually, it is there, but it is hidden in the graph. And this was presented by Lin, C.Y. Lin, the same Lin that Phil Payton talked about an hour ago. And this was published in 1994. And if you said, if this is the rate of uptake, and that is the amount of inhaled gas, which is inspired concentration times inhaled tidal volume, minus what is exhaled, alveolar partial pressure times minute ventilation, then that is the uptake. If you rearrange this formula, you come up with this, Fi times 1 minus Fa over Fi times Va. The assumption that is made here is that inspired minute ventilation is the same as expired minute ventilation. So if we look at the uptake, we see that it's a constant times 1 minus Fi divided by Fa. The graph above the curve, or the area above the graph here, the curve, is 1 minus Fa over Fi. And therefore, the area above the curve very well respects, with some assumptions that you have to make, very well reflects the overall uptake of your agents. The first small triangle here is the wash-in of your circuit, an FRC. You can look at this graph in a little bit more detail, and you can differentiate several areas where you first have uptake by the vessel-rich group, followed by more prolonged uptake by the muscle group, and then by relatively little but very prolonged uptake by the fat group. At the bottom of this slide, you will see the 3 times constant values for several of the agents, nitrous oxide, DES, SIVO, and ISO. Between parentheses, 3 times the time constant for the brain, the CNS. You see the time constants for muscle group and fat group. Fat group is days. So you could say that the higher, that the lower soluble agents have less uptake, because the area above the curve here, especially here, area above the curve here, is significantly less for the low soluble agents. So you could conclude from this that the uptake for these low soluble agents is less. But that's actually not true, because the low soluble agents also have a much higher MAC than the higher soluble agents. For example, if you look at sevoflurane and desflurane, at an alveolar partial pressure of 1.6 and 4.5 for DES, that is roughly 75% MAC. You see what the blood gas solubility is less soluble for desflurane, but actually the cumulative uptake is significantly higher for desflurane than for sevoflurane if you look at the total amount of vapor that is taken up. Therefore, we have to say that proportionally there is less uptake of the less soluble agents if you normalize for the MAC value. So in absolute terms there is more uptake, but relatively spoken there is less uptake. So we have to be careful what we say. But definitely there is an effect of solubility on the position of the FAFI curves. And we in general say, well, the faster the FAFI rises, the faster the concentration, partial pressure in the blood rises, the faster the partial pressure in the brain rises, therefore the faster our anesthetic takes on. In other words, it's a faster agent. Lower solubility agents are faster. They're faster in and they're also faster out. The question is, how clinically relevant is that? Who cares whether it's really faster? And I would argue that clinically, faster in is not really that important for several reasons. For example, first of all, you can overpressure in the beginning of the case. In other words, you can increase your FI significantly higher than what your target FA will be later on. So you can crank up your vaporizer setting and therefore your inspired concentration significantly higher than your target. And that is the use of overpressure. And a very good example of overpressure use is the use of liquid agent injection. And this is the result of a study that Jan and I did many years ago, but was never really published except it was mentioned in his PhD thesis. This was the fraction of MAC that we reached in alveolar concentration in the alveoli. And we approached 1.3 MAC of isoflurane, desflurane, and sevoflurane within 3 minutes. That was with liquid injection. That is the most powerful kind of overpressure that you can imagine, because it doesn't depend on your vaporizer power, on your vaporizer output.
And that's liquid injection in the breathing circuit?
Correct. This is liquid injection in the breathing circuit. So if you dare and you inject your agent fast enough, you can reach more than 1 MAC within 3 minutes. Now that's really fast. In other words, the solubility of the agent has very little to do, has very little impact on the rate of rise of your FA. It just depends on the technique that you use to administer the drug. A similar concept is used by a target-controlled anesthesia machine. With a target-controlled anesthesia machine, the rate of rise of FA becomes independent of agent solubility, cardiac output, minute ventilation, because you just set the target FA and the machine will do virtually whatever is necessary to reach that target FA within a certain time point, and that is to a certain degree controlled by you also. And when you use a technique like that, when you use the liquid injection or when you use a target-controlled anesthesia machine, the effects of changes of solubility, cardiac output, and minute ventilation are different from what we were told in the past. And we studied that by doing a gas mask simulation. And we looked at the mode of administration of inhaled anesthetic under interpretation of FA over FI curves. This is a gas mask simulation. And in the top part, you will see the classical technique FI constant. This is a typical representation of the FA-FI curves as described by Eager. High fresh gas flow, constant FI, and just observe what happens to the FA. If we have a low soluble agent in light blue versus a high soluble agent in purple, in this case desflurane and isoflurane, the effect of solubility means that, as we know from before, an increase in solubility will push the FA-FI curve down. It will push the FA down, and it will delay the rate of rise of your partial pressure in the vessel-rich group. This is what we know. This is what we have always been taught by Eager. This is a fact. It's well accepted. However, things are different when you keep FA constant, like in a target-controlled anesthesia machine. Now the machine will do whatever it takes to reach your FA very quickly. So with Gasman, we simulated that the FA was reached in less than 2 minutes. So we really used overpressure there. What happened now to the fraction in the vessel-rich group was that it was virtually the same. Not totally the same, but virtually the same. Good enough for a simulator, I would say. What happens to the effect of cardiac output in these two modes, classical Eager, constant FI? We know that an increase in cardiac output, the red curve, will push the FA down because there is more transfer of agent to the tissues in the body, more uptake. So there is more agent being washed away from the alveoli. Therefore, the rate of rise of FA is slower with a higher cardiac output. What happens with the FVRG is dual. In the beginning, we see that there is a faster rise of the agent because of the high cardiac output. There is more transfer of the agent to the tissue, so the agent gets there faster. But because the overall uptake by the body is larger, you will get to a lower plateau because you continue to deliver more agent to especially the muscle group. Therefore, the plateau is lower. This is, again, classical Eager. When they ask you a question like this on the board exam, this is going to be your answer. That's what happens. With a constant FA technique, however, things are different. Again, you set the machine. The machine is designed to reach your FA quickly and keep it there. What happens to the concentration or the fraction in vessel-rich group is actually the opposite of what the classical explanation tells you. Because you have a higher transfer of agent to all the tissues, your curve is shifted to the left and up. In other words, you reach a higher concentration faster with a higher cardiac output. And that is true for the vessel-rich group. But that is not necessarily true for the CNS, where the agent has its effect, because of cerebral autoregulation. We shouldn't assume that when the cardiac output goes up, that also cerebral blood flow goes up. That is probably a wrong assumption. If you have intact autoregulation, cerebral blood flow should not really change very much with increased cardiac output. So, although this curve is correct for overall VRG, it is probably not correct for the CNS. In other words, the effect of FA, keeping FA constant on the CNS is probably no different. We have not measured that. Nobody can actually measure that. But I think that's a reasonable assumption to make. What's the effect of minute ventilation? Classical Eager, increased minute ventilation in the dark green graph increases your rate of rise of FA. and therefore it increases your rate of rise in the vessel-rich group, classical eager. If we keep Fa constant, however, Fa is constant, and we see that the two curves are virtually the same in terms of rate of rise in the vessel-rich group. No difference at all. Gasman simulated this perfectly well. So the conclusion from this in terms of beginning of the anesthetic, I think that the importance of solubility is small because you can apply overpressure, but there is a limitation to how fast you can let the concentration rise. For example, with desflurane, you cannot let it rise very quickly because it's a pungent agent. You will have tachycardia and hypertension, which you don't want. So you don't want it fast. You don't want a really fast rate of rise of desflurane anyhow. So having a less soluble agent that allows you to a faster rise is not really important in real life. Also, most commonly we use IV inductions anyhow. And then we have about 10 to 12 minutes, the time to reach our target FA. Plenty of time, so there is no need for a faster rise than that. And then the importance of solubility is much less relevant in target control mode, as I showed earlier. In other words, solubility has not that much importance during the beginning of an anesthetic. It's not really that important. I want to come back to this part of the slide, and I think Jim will like to hear this one. What's the effect of solubility? In the right lower corner, I showed that the effect of solubility resulted in a slight decrease in rate of rise in the CNS, or in the vessel-rich group, I should say. And why would that be? Is this because of sloppy programming in Gasman program?
It's the brain-blood solubility.
It's exactly true. To rephrase the question, in targeted control mode with a constant FA, if the solubility has no effect on the rate of rise of FA, why does it still have an effect on VOG? And it's time constants the result of solubility. Exactly right. So what is time constant? You have heard about time constant a couple times today, but not everybody grasps what it really is. And what it is if you have a concentration of something in one container, and you're going to change that concentration by adding another substance that you keep flowing in that first container, how fast does the concentration change in that filled up lower bucket? And my analogy is, I came up with this morning when I was having a cup of coffee. The bottom here is your cup of black coffee. And the top here is you pour milk in at a fixed rate. How fast does the coffee disappear from your cup, and how fast is it replaced by white milk? That is very easy to understand. The time that it takes to fill up this cup with milk depends on the size of your cup of coffee to start with, and it depends on how fast you pour in the milk, right? There is nothing else that matters. And that is reflected by the time constant. The time constant is the medical expression on how fast this change occurs. And the time constant is calculated by volume divided by flow. The volume is the amount of coffee in my cup. The flow is how fast I pour in the milk in my cup. And we know that after 3 time constants, this is an exponential process, after 3 time constants, there's about 95% equilibration. So after 3 time constants, my cup is virtually all milk. No more coffee in there, or very little coffee in there. Most people say that 95% is virtual equilibration. Some people say 98. It depends on what number you like. So if we want to calculate the time constant of the CNS with vapors, we have to use a slightly different concept. Instead of volume over flow, we have to use capacity over agent transport. But it's analogous to volume and flow. So if we look at capacity of the CNS, then we look at the size of the organ times volubility of the vapor in that organ, while the agent transport into that container is determined by organ perfusion times blood solubility. Both of these factors should be multiplied by FA, partial pressure in the blood. If we calculate this time constant, all these parameters are known, then we see that the time constant for sevoflurane is 2.8 minutes, and for desflurane is 1.74 minutes. In other words, desflurane goes a little bit faster in, and that explains why the curve was shifted with desflurane, although FA was constant. It takes less time to wash in desflurane into the brain than it takes for sevoflurane to wash into the brain. So if this is the FA curve, we know that after the rapid initial rise, it kind of levels off and then gradually continues to rise. If we look at the alveolar partial pressure, we know that it's a little bit less, and Phil Payton told us why, because of the VQ scatter in the lungs. So the F small a curve is below the F big A curve. And the rate of rise in the CNS is determined by the time constant, of this case, the CNS. And that time constant is different for sevoflurane than for desflurane. So if the green curve is the one for desflurane, then the orange curve is the one for sevoflurane. So this explains why these FVRG curves were different when solubility was different. So it was not a program error in GasMed. It was real. It was very well modeled. So that's the explanation. It's almost the same. It's not quite the same. The effect, the reason is different time constant for different solubilities. The solubility has more of an effect during emergence from anesthesia. And most of the time, we concentrate on start of anesthesia, but we pay not as much attention to emergence. This is what we do when we teach residents also. We're there all the time when they start a case, but we're virtually never there when they finish a case. The solubility is important during emergence for four main reasons. There is faster lung clearance of a less soluble agent. There is the potential effect of isocapnic hyperventilation. I'm going to discuss that briefly. There's an increased chance of rehypnotization when hypoventilation occurs after emergence. And finally, there is importance of not just of blood solubility, but also of tissue solubility. Clearance by the lungs is very important. And this is a formula that comes straight out of Eager. It's minute ventilation divided by blood gas solubility times cardiac output plus minute ventilation. This is the formula that comes straight out of Eager. And it's intuitively very clear to understand that if you increase minute ventilation, you increase clearance from the lungs. The only way for the agent to get out of the body is through the lungs. So if you ventilate more through the lungs, more agent will come out. So that will speed up emergence. Clearance is faster. That's intuitively easy to understand. It's a bit harder to intuitively grasp what the effect is of blood gas solubility. And that's why I made this slide. In pane A, you will see what the effect is of solubility after equilibration. On the left-hand side, you see the situation before equilibration, amount of vapor molecules in the gas phase, in the alveoli. When you start off with with 9 molecules in the blood phase. This is what happens when blood returns to the lungs, to the alveoli. If you have equilibration and you have a blood gas partition coefficient of 2 times more molecules stay in the blood phase as compared to the gas phase. In other words, this is what happens. You will get rid of 3 of your molecules when you started off with 9, when the blood gas solubility is 2. When the blood gas solubility is a half, you will have 6 molecules ending up in the gas phase and 3 will stay in the blood phase. So when you go from a solubility of 2 to a half, you get rid of a lot more of the vapor molecules. And when you have a solubility of 0.111, you get rid of 8 out of the 9 gas molecules that were present in your blood. So this is a graphical representation of the importance of solubility on clearance. We did, again, model this in Gasman, and that clearly showed the effect of solubility on FVRG when we turned off the anesthetic. We started off, we anesthetized our Gasman patient for 8 hours at 1 mag. We turned off the agent, increased fresh gas flow so that there was no rebreathing, and we just looked what happened to the FVRG. And we saw that with normal ventilation, the FVRG reached 0.3 mag, or virtually close to mag awake, after about 14 minutes, with CVO 8, with DES about 6. In other words, there is an effect of solubility on the emergence time. Also, we all know that. Then a trick has been used to speed up emergence. And if you increase minute ventilation during emergence, you will improve the clearance, you will wash out more agents, so the patient should wake up faster, right? So that's the model that we used. And with hyperventilation, you have increased lung clearance, but cerebral blood flow goes down because of cerebral autoregulation. When you decrease CO2 through hyperventilation, the cerebral blood flow goes down. That hinders the removal of your agent from the brain, and therefore this is counterproductive. The solution for that is to use isocapnic hyperventilation. You add some CO2 to the circuit to maintain normal capnia, or you can even increase end-tidal CO2 a little bit, so that you at least maintain cerebral blood flow, so that doesn't work against you. So what happens then when we simulate this? And Gasman is thankfully a very good model of isocapnic hyperventilation if you increase minute ventilation, because it doesn't take into account the effect of hyperventilation on cerebral blood flow. So it's a good model for isocapnic hyperventilation. Not intentionally maybe, but it is.
But not regular hyperventilation.
What we see with hyperventilation is that these curves are shifted to the left. In other words, with isoflurane, you cut off about 5 minutes of your emergence time, while with desflurane, you only gain 1 minute or so. The question now occurs, what happens after the patient indeed wakes up, and then, as frequently occurs, hypoventilates a little bit, because of the opioids that you have administered, because you're not pounding him anymore to wake him up and make him breathe and whatnot. You leave him alone now, and now the patient starts to hypoventilate. What happens with hypoventilation? And are the graphs for isoflurane. This is the initial graph of emergence on the left for normal ventilation and hyperventilation. What happens when you hypoventilate now after extubation? And I have several different settings for minute ventilation: 2.5, 1.5, 1, and 0.5 liters per minute. So if you hypoventilate, I would say a little bit, 1.5 liters per minute of alveolar minute ventilation, that is mild respiratory depression, I would say. With isoflurane, your vessel-rich group, isoflurane concentration goes back up and goes way above mag awake. In other words, your patient becomes rehypnotized, goes back to sleep. Subsequently, they may lose their airway, they may hyperventilate more, and quickly the patient will be in trouble. Sevoflurane is a safer drug in that regard, because with a hypoventilation of 1.5 liters per minute, your brain partial pressure will continue to go down. So in this case, you have to hypoventilate a lot for your patient to become rehypnotized. While with desflurane, it's very unlikely that your patient will ever hypoventilate to such a degree, this is after an 8-hour anesthetic, to become rehypnotized. In other words, agents with a low solubility will get you a lesser chance of rehypnotization. And those who say that rehypnotization never occurs, I've had at least one very well documented case of rehypnotization. So it does occur, rehypnotization as a consequence of hypoventilation. So for emergence, we can say that it's faster with less soluble agents. Isocapnic hyperventilation shortens emergence time, and that's more significantly so than more soluble agents. But subsequent hypoventilation can result in hyporehypnotization, and that is more so with the soluble agents, and that is slightly more so after hypocapnic ventilation. So if you look at the isoflurane curve and you look at the left curve of these two, VA 1.5 liter per minute, you will see that with initial hyperventilation, isocapnic hyperventilation, the FVRG rises a little bit higher than if you use normal ventilation to wake the patient up. So there is an effect of hyperventilation that is not beneficial, a potential effect that is not beneficial with the more soluble agents. So the question rises, is it worth doing? You have to modify your circuit, you have to add CO2, it becomes more complex. Is it worth doing? And in my opinion, it's probably not. You may save a couple minutes, 2 minutes with the modern agents, probably not worth doing. It's very interesting to study from pharmacokinetic point of view, because this is all very interesting stuff, I think. Not just the blood solubility is important, but also tissue solubility is more important to explain all this. And that is again because of time constants. So the shorter time constant results not in just faster in, but also faster out. And if we look at the time constant of CNS, it's capacity over agent transport, and that is volume CNS times solubility of CNS over gas, divided by perfusion CNS or solubility in blood and gas. If we rearrange this formula, we see that these parameters are constant and that on the right, these parameters are variable for the different agents. So if we look at that parameter on the right for different agents, we see that it's higher for isoflurane and sevoflurane than for desflurane, and nitrous oxide has the lowest value. In other words, nitrous oxide is much faster out than any of the other agents. And I'm going to stop right here. Thank you.